Let's get into it. Today we'll be talking about teriparatide. So to start off, we'll discuss a little bit about parathyroid hormone, its functions. Then we'll get to teriparatide, how it acts, indications, contraindications, the whole deal. All right, let's get to it. First slide. So teriparatide, what is parathyroid hormone? First of all, it is a hormone which is produced by the parathyroid glands, which are four tiny glands on the posterior aspect of the thyroid, as you can see in this diagram here. So, what is the function of this parathyroid hormone? So, the parathyroid hormone, which is an 84 amino acid chain, it's a peptide hormone. 84 amino acids make up parathyroid hormone. They act directly on bone and they act on the renal tubular cells. So, their function in the bone is it stimulates bone turnover. Bone turnover, very important term. It stimulates calcium release from the bone mineral compartment by stimulating osteoblastic cells, which indirectly stimulate osteoclastic cells. The mechanism is not very important, but I'm just telling you the functions. Then, in the renal tubular cells, it stimulates calcium reabsorption. The main goal of parathyroid hormone is to increase calcium levels in the blood by any way possible. So, whether it takes calcium from the bone, increases calcium reabsorption from the kidneys, which from the urine, and it also inhibits phosphate reabsorption. So, it increases calcium levels in the blood and decreases phosphate levels in the blood. So, it inhibits phosphate reabsorption, and also more importantly it stimulates 1 alpha hydroxylase. So what is 1 alpha hydroxylase? 1 alpha hydroxylase is an important enzyme to convert vitamin D to its active form, which is 125 dihydroxy vitamin D. It converts 1 hydroxy vitamin D to 125 dihydroxy vitamin D, which in turn indirectly acts on the kidney and increases intestinal calcium absorption. So all these three functions, increasing calcium release from bone, increasing calcium reabsorption from the kidney, and increasing calcium reabsorption from the intestine, all increase serum calcium. So the parathyroid gland has a calcium sensing receptor. So if the calcium level in the blood increases too much, PTH release decreases, and if calcium level in the blood is low, PTH release increases. So with that basic concept, let's move on. So as you can see, teriparatide is a recombinant human parathyroid hormone analog. So what that means is a PTH has 84 amino acids. As you can see, teriparatide has only 34. It has only 34 of the amino acids which are used to make PTH. So it's a shorter peptide hormone and it acts like parathyroid hormone, but slightly differently. I'll tell you what that means. Coming to what bone turnover. So as we see, the bones we see are not what they seem to be. What I mean by that is, at a microscopic level, bone is always being reabsorbed and deposited in the bone. It's a constant cycle. Bone gets reabsorbed, deposited. So this is what I mean by bone turnover. In the growing phases of our lives, we want more bone formation. So bone formation is greater than resorption. When we come to the middle age, bone formation and bone resorption are almost equal, as you can see in this diagram. Whereas when we get older, especially in postmenopausal women, bone resorption far exceeds bone formation. And if bone is being more resorbed than it is being deposited, what happens? It leads to osteoporosis. So that is the mechanism by which osteoporosis occurs. So what parathyroid hormone does is it increases bone turnover. So one more important point that I forgot to mention and which everyone should think about is, so think about it logically. Parathyroid hormone increases the bone turnover and it increases the calcium level in the blood. And teriparatide, which is an analog of parathyroid hormone, is used for treating osteoporosis, a condition where there's already low calcium level in the bone. Does that make sense? It does not. Makes no sense because those are two totally opposite things. So why is teriparatide and how is it used for treating osteoporosis? The thing with parathyroid hormone and teriparatide itself, so their action is based on the duration of dosage. So what I mean by that is, if we give parathyroid hormone for a long period of time, initially it's anabolic, and then it reaches a point where the anabolism and catabolism equalizes, and slowly eventually it becomes catabolic. So just like that, with teriparatide, what happens when we give the hormone initially, the bone formation is greater than the bone resorption, and then it reaches a point where it evens out. So this duration where the bone formation is greater than the bone resorption because of teriparatide is called the anabolic window. And for teriparatide, it's about 18 to 24 months in duration, which is also why the recommended duration of treatment with teriparatide is about 2 years. Anything less than that is less than optimal. So, with that in mind, you can see with this anabolic window diagram that as it reaches around the 24-month mark, what happens is the bone formation markers decrease and the bone resorption markers tend to overtake that. It's also falling, but you can see bone resorption is higher than bone formation. So the anabolic window effect of teriparatide is gone. Also, one more important thing to keep in mind is, in studies done, it was noticed that when PTH was given in a continuous infusion form and even teriparatide, the bone resorption eventually became greater than the bone formation, which is why we also give teriparatide in an intermittent fashion, like a small dosage every single day. Nowadays, research has come out where we can even dose it weekly. I'll talk about that in the next coming slides, but this is why we also give it intermittently. Coming to the next slide. So, how does teriparatide act on bone? So, teriparatide acts differently on cancellous and cortical bone. Its function mainly is on cancellous bone. Its function on cortical bone is almost net neutral or even slightly catabolic or slightly anabolic. What I mean by that, I'll tell you in the next slide. So, what I mean by anabolic in cancellous bone is it increases the amount of calcium, it improves the microarchitecture, and it improves the density and also improves the geometry of the bone. And I'll show you a diagram. So you can see in this is a native patient which has not received any osteoporosis drugs, and after 24 months of teriparatide you can see improvement in the bone macroarchitecture. And even in a patient who has received alendronate, after 24 months of teriparatide you can see vast improvements in the bone architecture. So when do we use teriparatide? Usually in postmenopausal women with severe osteoporosis. So usually with a T-score greater than 3.5, but I just put 2.5 because anything above 2.5 T-score is considered osteoporosis. Anything greater than 3.5 is severe osteoporosis. Osteoporosis in postmenopausal women, older men. Some patients we give glucocorticoid, and what a glucocorticoid does is it causes osteoporosis secondary to its treatment. So we can treat that with teriparatide. And another important indication is any patient with a fragility fracture. What do you mean by fragility fracture? Any fracture that has occurred in, like, for example, in case of very low energy trauma, fall from standing height. So basically, the amount of force applied and the fracture which has occurred does not correlate. Contraindications of teriparatide. We do not use them in children with an open physis. In already hypercalcemic patients, like in patients with hyperparathyroidism or high calcium for any other cause, in patients with bone mets, and in patients with high alkaline phosphatase of any cause. Even if we don't know the cause, we have to first find out the cause of high alkaline phosphatase and then consider treating with teriparatide. So this is another chart which shows the what I was talking about before, how it acts on cancellous bone more than cortical bone. You can see here lumbar spine is mainly cancellous bone. Other than the two vertebral end plates, the filling of the vertebral body is mostly cancellous bone. So as you can see, there's nearly a 12%, 10 to 12% increase in the bone mineral density over a period of 18 months. Here, when it comes to the hip is a good mix of cancellous and cortical bone. So you can see there's about a 3 to 4% increase in bone mineral density compared to placebo. Interestingly, in the distal radius, which is more cortical than cancellous bone, you can see there's a catabolic effect. The bone mineral density is decreased even before uh, its normal state. So the bone mineral density has decreased rather than increased by around 1%, which is negligible because this slight increase in cortical porosity is compensated by the improvements in bone microarchitecture. And you can see even compared to alendronate, the action on bone mineral density is far superior in teriparatide. You can see 4% and then there's 8% in teriparatide's case and 4% in alendronate in spine and about 2.5% in hip and 4% in teriparatide. So prerequisites, what blood test should we do? We should make sure that the patient has good vitamin D levels, the serum calcium is within normal limits, alkaline phosphate is within normal limits, and some insurance companies require us to do a DEXA scan in order to justify teriparatide. So we might have to get a DEXA scan and prove that the patient has osteoporosis. How do we dose it? The commonly given dose in our country as of now is 20 micrograms or 8 units every day subcutaneously. But enough research has come out, and there's even more research going on saying that 60 micrograms dose weekly is also very effective and almost does the same job as 20 mcg every day. So 20 mcg every day over a week is 140 mcg, where 60 mcg weekly is nearly half that dose, and also more importantly, it's cheaper, more economical, and patient compliance. If you tell someone they have to inject themselves subcutaneously for an entire 2 years, it's kind of difficult to explain that and convince them. Whereas if you tell them once a week injection for a period of 2 years, they're more likely, to be compliant with therapy. Duration of therapy is about 24 months or 2 years, as I explained, the anabolic window period. We should monitor calcium and vitamin D levels throughout, and along with teriparatide, we should give them calcium and vitamin D supplementation, about 1000 milligrams of calcium and 1000 international units of vitamin D, which is a maintenance dose. What are the possible side effects of teriparatide? Some older individuals, especially with the 60 mcg weekly dose, because of the larger dose, they experience orthostatic hypotension. As you know, that's a disaster in older people. We are trying to prevent fractures, and we do not want to cause a fracture when they fall. So just tell them to watch out for that and be wary. And of course, hypercalcemia because of the inherent nature of teriparatide. If we watch out for these two main side effects, the other side effects of teriparatide are more or less negligible. And yeah, that will be our. So, summarizing today, teriparatide can be given in case of fragility fractures, in case of T score 2.5 to 3.5 based on patient to patient basis. What I mean by that is, in a patient greater than 75 years with 2.5, we might want to consider giving rather than a patient who's 50 years with 3, because who's more likely going to get a fracture? Of course, the elder individual with probably worse bone microarchitecture. And even though the BMD is better in her case, she is more likely to fall and injure herself and fracture. And for example, imagine the patient comes to you who is already on bisphosphonates and they have a fracture. We can start them on teriparatide. Why? So what's the main difference between bisphosphonates and teriparatide? Bisphosphonates are anti-resorptive, teriparatide is anabolic. Bisphosphonates are anti-resorptive, meaning they just prevent the decrease in further bone mineral density, whereas teriparatide increases bone mineral density. So, teriparatide is definitely a superior drug to bisphosphonates. And yeah, that'll be it for today. Thank you.